Director of the CUNY Institute for Implementation Science and Population Health. We're bringing you public health grand rounds today. It's great to see so many people wearing red in solidarity of our teachers union here at CUNY and our lack of a contract. Thanks for that. Even my daughter got into the mix. She hand knitted me a very nice red little pocket thing here for today. Last night she did that. I'm very pleased to introduce our speaker, Dr. Jacob Bohr, today for our public health grand rounds. Dr. Bohr is an assistant professor in the Department of Global Health at BU, Boston University, and he has a secondary appointment in the Department of Epidemiology there. His research interests include health policy and socioeconomic determinants of health outcomes. His research is primarily a global focus with a focus on HIV in South Africa as well. He's done some really important work advancing and applying quasi-experimental methods to observational data, which is one of the reasons why we were excited to have him come talk to us, including regression discontinuity design, and he's published several important and sometimes high-profile papers applying these methods to his own research in recent years. He's also done some really interesting big-picture work on socioeconomic inequalities in the U.S. that when Sandro Galea was here speaking to us at the end of last year, he spoke at length about, and very fascinating, long history and interpretation of what's been going on in terms of inequalities and the relationship to health and their trends. Jacob's a Harvard man all through and through, undergrad through master's and doctorate, and he has a K Award from NIH that is focused on causal inference methods to evaluate spillover effects of HIV treatment scale-up on economic health and behavioral outcomes. And today he's here to talk to us about the elusive end of AIDS in South Africa. Jacob, welcome to CUNY.
Okay, thank you, Dennis, so much for having me here, and to everybody who I've met over the course of the afternoon. It's been really great to hear about the work you all are doing. How do I advance the slides here? Just an arrow? Yeah. Perfect. So it's the end of the day, and I want to make sure that I'm going to talk about a bunch of different things, but I want to make sure that if you hear something that you have a question about, if you can just throw up your hand, because I would much rather have us have a little bit of interaction through the course of this. I won't be able to take every question, but I would very much value understanding what is resonating with you or not resonating with you, if that might be the case. So here we go. No conflicts of interest to disclose, but would like to acknowledge collaborators at the National Health Laboratory Service in South Africa, at HERO, which is the Health Economics and Epidemiology Research Office in South Africa, at ARI, the Africa Health Research Institute in KZN, South Africa, and at Boston University. So one of the most important contextual determinants of HIV risk is the prevalence of infectious virus in the population. Here's a population where 5% of potential partners are infected. Here's a population where 35% of potential partners are infected. This is what it looks like in the general population in rural South Africa, which is where I've done my dissertation work and where I've been working since 2005. This is that same population where 6 out of 7 of these people are on antiretroviral therapy. This is the promise of HIV treatment and prevention, that with viral suppression from antiretroviral therapy, people living with HIV are no longer infectious, and that the contextual, the context, the environment that structures transmission has been fundamentally changed. So this is the promise of this intervention. In South Africa, ART has scaled up dramatically since it was first introduced in the public sector in 2004. I note that that's 8 years after it came on the scene in the U.S. and was prohibitively expensive in South Africa in the private sector, and it wasn't until there was a massive movement both in South Africa and internationally to reduce prices of drugs that the scale up actually happened. But we're now sitting in 20. I guess the latest data that this shows through 2016, but there are about 4 million people on HIV treatment in South Africa, the largest of any country in the world. This scale-up has had dramatic impacts on population health. So sort of, on first blush, looking at questions of mortality and life expectancy, this graph shows period adult life expectancy, that is the average age to which someone can expect to live from age 15. And it increased from under 50 years to 67 years in the wake of HIV treatment scale-up. And these are gains that are sort of one might see at the end of a famine or war, but as a result of a public health intervention, in a therapeutic public health intervention nonetheless, is virtually unprecedented. Those were the direct health benefits. But increasingly, and since 2011, definitively, there's been a recognition that treatment is not just therapeutic, but it's also prevention. And so the HBTN-052 trial found a 96% reduction in transmission. Partners 1, Partners 2, and opposite attract cohorts have now found 0 linked HIV infections in 126,000 condomless sex acts and serodiscordant couples. So the answer to whether you can transmit if you're virally suppressed is no. And the upper end of that confidence interval is getting closer and closer towards 0 as more and more data accumulate. So this has been, the word game changer has been thrown around a lot, and that is certainly true. So treatment is being scaled up. How would this affect the epidemic? There have been modeling studies that have shown that if you could actually scale up treatment to enough people, you could actually end the epidemic, right? By not just by allowing people to live longer, but also by interrupting transmission. By doing that to enough levels that this green curve shows. This is from the Ruben Granich article in 2009, which sort of got people thinking, was an important article in getting people really thinking about the potential of treatment as prevention, that universal voluntary HIV testing and immediate ART of everybody would see incidence plummet essentially to 0 immediately. And this has been the major public health rationale for changes in WHO guidelines to eliminate CD4 thresholds and extend treatment eligibility to everybody, and to institute policies that are now being embraced around the world, including in South Africa from 2016, to treat all, or test and treat, or universal test and treat. And these words are used approximately interchangeably, but with the idea of getting as many people on therapy as possible. Will it work? Has it worked? Early evidence from population-based, randomized population-based trials has been less encouraging than one would hope based on the evidence from serodiscordant couples. So the ANRS task trial, which was actually conducted at RE in rural KwaZulu-Natal, South Africa, randomized communities to treat all, universal test and treat, versus standard of care. They went house to house, they tested people. People who tested positive were given a referral to a local clinic where, regardless of CD4 count, they could start ART and get onto therapy. The impact of this intervention was 0. The hazard ratio for HIV incidence was 1.01. So this flat out did not work in terms of changing incidence. And the researchers, importantly, collected a whole bunch of data on what happened, a deeper dive on sort of what happened along the way. What they found was that even though they were going house to house, there were no differences actually in any of the steps from linkage to care in terms of people actually making it to the clinics and starting treatment. So fine, you can test people, but if there's no differences in whether people show up at the clinic, and no differences in whether people conditional on showing up at the clinic start, then you're not going to see any impact on incidence, right? The critical mediating variable of population viral load is not changing here in this context. So what this reveals is that effectiveness of treat all, or test and treat, is going to depend on behavior and interactions of behavior in institutions and health systems, not so much on the biological efficacy, where the evidence is completely clear. I'll argue in this presentation that measuring effectiveness rather than efficacy requires new designs, study designs, and new kinds of data. And I'll also argue that understanding the gap between efficacy and effectiveness is going to require a more person-centered approach to public health research than we've previously been thinking about. Rather than thinking about patients as widgets that need to be moved through a care cascade, we actually need to interrogate the context in which patients are making decisions, how they're thinking about the decisions that they're making. And in doing so, we're going to encounter head-on some critical ethical dilemmas that HIV treatment as prevention raises, which I'll get to shortly. So has test and treat worked? Well, evidence from recent population-based survey in South Africa suggests that South Africa is still pretty far away from the UNAIDS 90-90-90 targets. For 90% of people living with HIV knowing their status, 90% of people on ART, of those on ART, and 90% of those virally suppressed. The numbers are 85, 78, and maybe 88. So, a couple of those are pretty close, but the share of those who know their status who are on ART is not as high as one would hope. And when you multiply all these together, you find that at the end of the day, just about half of people living with HIV in South Africa are still not virally suppressed. If you go to an HIV conference these days, you will see a gazillion graphs that look like this. Every country is making them, every district in every country is making them, and this has been sort of promoted as the way that we're going to get to success on treat all is by sort of tuning these knobs along this cascade. But it's often based on cross-sectional data. And so upstream changes in who you test are going to have implications downstream. It's kind of hard. It doesn't actually point to where the problems are. So we actually need longitudinal data on how individual patients go through the cascade in order to understand where the weak link. Longitudinal data, representative longitudinal data. We may need to leverage the kind of administrative data that the surveillance group here in New York City is using to see how people move through the system. In South Africa, there's no national system that includes everybody, but the National Health Laboratory Service, as a lab system, conducts all laboratory monitoring for the whole public health care system. And so they do all CD4 counts and viral loads and all other HIV-related laboratory testing for the entire national HIV program, and they store all that in a database. The issue is that this database of complete lab records has no unique ID, so you can't follow patients through this system. Even though there's data on everybody, there's no way to follow patients through the system. And so with collaborators at NHLS, as well as the University of Witwatersrand in South Africa and at BU, we developed a record linkage algorithm to enable us to transform this national laboratory database into a national HIV cohort. To our knowledge, this is unique in its ability to actually observe every patient in an entire country at every facility as they move through the system. We don't have dense data because we don't have clinic visits and other things, but we have everything that we can see through the labs. To do this, we started with about 150 million lab test results. Those were different tests conducted on about 117 million different specimens. Those specimens corresponded to demographic patient identifying information for about 63 million different sets of identifying information that we then reduced to 11.6 million what we're calling unique patients. To do this, we used sort of traditional probabilistic record linkage procedures, but we also incorporated methods from network analysis in order to help guide the linkage, which was important for a data set and population that was this large. And I can get into further details on that if people have other questions. We validated this relative to a manually matched gold standard of about 60,000 candidate match lab results that we had RA's triple code. The linkage attained 99% positive predictive value relative to the manual match and 94% sensitivity relative to the manual match. So this means that if we observe that two specimens are linked together, then it's 99% chance that that's true. And if a patient has two specimens, then we identify that link in 94% of the cases. We also, there's a small share of the population for which we observe national ID numbers and have very high sensitivity relative to those national ID numbers. The cohort estimates, based on the cohort, we estimated just over 4 million patients on treatment in 2015, 2016, which is very close to the within 100,000 from the NDOH numbers. And this is what we arrived at, not shooting for that number. We were not aiming for that number. This is what the procedure revealed. And again, what this allows us to do is it allows us to follow longitudinally all patients in the National HIV Program from first CD4 count to viral load to ART workup, lab workup, through virological monitoring and viral suppression. And South Africa, like many countries, has very sort of rigorous, clearly specified guidelines for when you should do labs. And so we are leveraging the fact that there are these specific guidelines, which are widely followed in order to interpret what's going on in terms of patient care. So let me show you some results. So one thing we find is that even in this era, patients are continuing to present with low CD4 counts. So maybe a third of patients, 35% of patients are presenting with a CD4 count below 200. We find that many who start are not retained in care, but the dotted line shows you those that are retained at the initiating clinic, and the solid line shows you those who are retained within the whole healthcare system, because we observe when people transfer to other clinics. And so even though things aren't great, they're better than people had thought previously, because most other studies are just showing you the dotted line, and we're able to actually follow people up when they go to another clinic. This shows you some of that movement across the country. How has the most recent, that stuff's published, what I'm going to show you is some unpublished work in progress. So how has the rollout of Treat All in September 2016 affected South Africa's care cascade? The first thing is that there's been no change in numbers of patients presenting for care, which were proxying with having the first CD4 count on file. So this is, gently sloping down across the whole period, because fewer people over time are seeking care as the people out of care is getting smaller and sort of more saturated. But you would expect for the rollout of UTT, Universal Test and Treat, for there to be an increase in testing and an increase in linkage to care and people entering care, and we don't see it. We don't see evidence of that. In 2017, in the UTT era, here's the distribution of CD4 counts at presentation. The majority, over 2/3, are below 500, and thus would not have even been affected by the elimination of CD4 thresholds. We do see over time a marked increase in ART uptake, at least as proxied by the availability of an ART workup. And so what this shows you is and I pirated this this figure from an excellent study that some folks here have done on the IDEA cohort. So that's why Dennis is laughing. So what this shows you is 4 different eras. In the bottom is the era before 2011, when when someone was only eligible for ART if they had a CD4 below 200 or had stage 4 illness. The red line, the next line up, shows you the period from August 2011 through December 2014, when the threshold had moved to 350. The green line shows you the next era when the threshold is at 500, and then the yellow line at the top shows you the UTT era. So the first thing you can see is that there are these jumps in the previous eras, which happen exactly at the threshold, because the threshold matters, or mattered, right? People were being prevented from starting treatment as a result of this threshold. Okay? And so that's the first thing that you see, and you see that in the test and treat era, the threshold goes away, which is what we expect because there's no threshold anymore. The next thing I want to point out is that the size of those jumps at the threshold, they don't go from 0 to 1, from 0 to 100. They're 10, 15 percentage points at most. Okay? So there are a lot of folks here who are initiating kind of regardless of being eligible, and there are a lot of people who are not initiating regardless of not being eligible. So that's the second thing. The third thing is, if you focus just below 200, the people who've always been eligible, there's an increase over time in the share of eligible patients that are having an ART workup. And this, I think, reflects both an increase in actual initiation as well as a compression of the early cascade of care, as more and more fewer visits are required from diagnosis and presentation to when someone actually starts treatment. And in South Africa today, many clinics have moved to same-day initiation, where you're getting your CD4 count and ART workup on the exact same day. Okay? So there's been this compression of the cascade at the very front, and many more people are starting treatment. That's the good news. Here's the not so good news. This shows you the exact same figure, same denominator. These are, again, people presenting for care with a CD4 count, same denominator. But rather than showing you the share with an ART workup, this shows you the share that has the documented suppressed viral load in the first year. So even in the treat all era, you see the bumps, right? So you see the bumps from the previous year, like treatment works, it suppresses people's viral load, this is good. But even in the treat all era, we're at less than 50% of people who are presenting to a clinic with HIV, known to have HIV, have a CD4 count taken on file, and are not retained in care through viral suppression within the first year. And it's possible that some of this might be due to some gaps in linkage, which are things that, in our record linkage, which are things that we're working on exploring and seeing how robust is this. But one way to just kind of get a gut check on this is to look with another data set. And so these are data from a colleague of mine, Dorina Noya at Hero in Joburg, who conducted a study with a similar idea, but completely different data set, extracted data from clinical charts, and looked at the proportion of patients who were diagnosed at 2 public sector clinics in Joburg who showed up again at these different months after diagnosis. And so we go from 100% down to 50% almost immediately. And if you sort of look across this whole period, only about 45 to 50% of people are actually retained in care in the first year. So this is concerning. This kind of adds all this up and says, well, what does the cascade look like in the pre-UTT era, in the era with the 500 threshold, and in the UTT era? So the first bar is scaled to 1 to 100% for presented in care. And then the red bar shows the increase in ART workups. The green and orange bar show very, very small increases in the share of people that are being virologically monitored and virologically suppressed in the first 12 months. this is bleak, but it's not new. And I think that I'm going off script, but one of the things that I think we've done a disservice to ourselves is in not seeing clearly what's actually happening. And a lot of studies have, for example, started at treatment initiation and seen that, look, if we have people initiating, then they're staying on in the pre-UTT era, which is true, because by the time someone actually initiated treatment, we'd already screened out the people who weren't that interested. And nowadays, people who are starting treatment are actually less likely to stay on therapy than they were previously. And it's not because we're doing the wrong thing. It's not because like UTT is a bad policy or we shouldn't start people on the same day, but it's because people who were previously dropping out of care are now dropping out of care. So this shouldn't be so surprising, but I think it kind of highlights, it's a bit of a reality check, I think, about like where we are in thinking about the cascade. All right, I hope that's not too bleak. All right, so I want to shift gears a little bit and say, if we want to address some of these issues, how do we do that? And I'm going to frame this. I'm going to shift gears a little bit to talk about some ethical questions that come up, and I'll bring things back together. So with treatment as prevention, we've seen this amazing shift in science. U equals U. It's true. Tremendous promise in model. This should end the epidemic if we can actually do this, right? Shift in policy. Countries, UNAIDS is setting targets. WHO is changing guidelines. Countries are pursuing this. This is the strategy that's going to get us there, plus PrEP and circumcision and stuff like that. But really, those are footnotes to the dominant strategy, which is ART scale-up. So, but I think we haven't fully considered the ethical dimensions of what we're trying to do with TASP. And we need to do that in order to scale up TASP both ethically and also effectively. The old paradigm was the right to medicines paradigm. Healthcare is a human right. It's a positive ethical obligation to provide medicines to people. The demand was universal access to treatment when you need it. And this is a pivotal approach in AIDS activism and in the legal battles that reduced drug prices and allowed for ART scale-up. Essential. Some pictures from that era. TASP raises new ethical questions, though. There's a strong public interest in patients starting ART, but private interests might differ. There may be a gap between what is privately optimal and what is socially optimal. In economics, we call that an externality. Okay? If there's this conflict between, and as a result, there may be a conflict between the goals, societal goals of increasing ART coverage to reduce community viral load and reduce incidence, and the ethical obligations that we have to individuals. And I think we haven't fully grappled with this tension, and that's clouded our eyes. At least I haven't until I started thinking about this recently. So if you feel like this is, yeah. I think this helps to both think this through ethically and think about how we can scale up this intervention with large social benefits effectively. So this is actually not a question just about TASP. This is a question we deal with all the time. So child immunizations. There are community protections. You can't enroll in school unless you vaccinate your kid, right? I should have put the measles headline up here. On the other hand, there are individual protections, right? There are religious exemptions from vaccination. Flu. There are community protections, widely publicized drives, get your flu vaccine, someone comes to the workplace, it makes it super easy. At the same time, there's individual protections, voluntary except for medical, and elderly care professionals. This is sort of a more communications-based approach. No more excuses, get your flu shot. TB treatment. Here, actually, we can quarantine, take people's liberty away as a public health community if someone has infectious TB and they refuse treatment. But there are also patient protections. This is if all else fails and is a risk to others and there's a court hearing, so there are legal procedures there. But this kind of like shows you, for this classic problem, like how do we achieve the social benefits when there might be like this discordance between the social optimum and the private optimum? Like how do we do that? There are different options at our disposal. HIV treatment prevention is different, right? It's relatively hard to spread. There are other ways to prevent it. Treatment requires lifetime therapy. It's not just a flu shot. Many of it is different, but the fundamental question and the ethical question is actually the same. So why are we talking about this anyway? I mean, why don't people living with HIV just start treatment like the global HIV community thinks that they should? So I would say that there's sort of two ways that folks in HIV, implementation science, maybe I should say, think about patient behavior or care-seeking behavior. And first is this cascade of care narrative, where patients are stalled at discrete decision points. They haven't tested, so we got to get them to test. They haven't linked, so we need to take them to link, or we need to bring linkage to them. They haven't started, so we need to get them to start. In fact, even on the same day, they aren't staying, so we need to figure out how to get them to stay, and we'll even deliver the pills to them, right? So there's that. The second is, I think, the black sheep, which is the demand for art approach, which is that patients may have preferences, which are deeper preferences, and well-formed preferences, which affect behavior change throughout the care cascade. And this would be consistent with when you initiate people the same day, the people who were previously dropping out of care before ART are now dropping out of care after ART. This would be more sort of consistent with that perspective. And here the goal is to try to understand and perhaps to change the actual or perceived costs and benefits of being on lifelong daily therapy. These two approaches, or these two narratives, have radically different ethical implications. Because if we don't acknowledge patient preference, it kind of doesn't matter. We're just trying to turn these control knobs. But if we take seriously that patients have preferences, like are people, and ... have rights and dignity, ... don't just care about their health, but care about other things in their lives, ... If we take that seriously, then we start to see where this tension arises between the goals of task and the goals and private goals. So why do some patients not start? Well, the direct benefits of early ART are modest. START and Temprano unequivocally showed that you should, all else equal, you should start immediately versus defer. That is, I'm not arguing with that. Highly significant relative risks. But the actual underlying magnitude of adverse events here in the control group is fairly low. In fact, you need to treat 60 to 120 person years you need to provide 60 to 120 person years of ARVs to avert one non-fatal morbid event. And there was no effect on mortality in these studies. This is not, again, I am not saying that clinicians are doing the wrong thing or that we shouldn't encourage people to start immediately. It is better for their health. But the magnitude is, I will let you tell me whether you can think in your own life whether this is modest or not and compare it to other risks that you face. Let me put it that way. By contrast, the cost of healthcare utilization of even nominally free therapy can be high. So this is a study that we did in rural South Africa where we looked at a monthly healthcare expenditure and a survey of people enrolled in free HIV care in the public sector, and found that between travel time and travel costs and additional wraparound care and time at the clinic, people were spending a fair amount of resources, like on the order of a third of median per capita income. That's a lot of money. Now, per capita income is really low in this setting, but that's a lot of money. And 40% reported that they borrowed monies or sold assets to pay for care. So remember, we're asking people to do this for this. But there's more. There's significant non-financial costs. We were interested in this question of demand for art and thought, here's a tracer population. People who actually have revealed that they don't want to start, or who don't start, and then we can ask them, why did you not start? And I'm not a qualitative researcher, and so I don't have expertise in that, but there are lots of really good qualitative researchers who've asked this question, and so we did a systematic review of the qualitative literature to say, are there reasons that people are saying in different contexts in South Africa and in Kenya and in Guinea, like similar things, and are there things that are coming out about why people with HIV are choosing not to start treatment? And a number of things came up. The hassle of lifelong daily therapy, the perceived side effects of treatment, the association of treatment with sickness, sort of rather than health. If people are being asked to start when they're feeling well, it's hard to start taking medicines that make you think that you're sick or make you actually feel sick. Exposure to stigma or rejection if you show up at a clinic, because taking drugs is often the most clear signal that a person is living with HIV. And finally, mandated lifestyle changes. And I don't know if there's a robust discussion about this. I haven't been privy, but this came up a lot, that people didn't want to stop drinking, and they didn't want to stop having unprotected sex, and they didn't want to stop smoking, and all the other things that the doctor was telling them to do if they wanted to get drugs. Now, as far as I can tell, there's zero evidence for any of those recommendations. And I'm happy to talk with people afterwards, because I did do an extensive search on all of these things. But as far as I can tell, there's not evidence for these recommendations, and yet there's this sort of moralistic approach that you need to turn your life, you need to turn your life around, or to have a kind of penance of behavior change in order to be worthy of art. And that sort of salvation narrative is preventing people from having access in a lot of cases. So what do we do? How can we ethically and effectively motivate greater uptake of HIV testing and treatment? Here are 5 options. Coercion. This is what we do with TB. I'd suggest this is not a good idea. Activists have railed against this for years. There's no imminent transmission risk. It takes 2 to tango. There are other options to prevent. It's highly stigmatizing, and there's unintended consequences for care seeking. If I think that, I'm going to be coerced to start therapy, why the heck would I ever pitch up to a clinic to test? So, this is, I think, for completeness included, but I think pretty quickly off the table. We could pay people. This is what the economist would do. If there's an externality, internalize it. Get the prices right. If you get the prices right, people will provide the right level of treatment-seeking behavior that is socially optimal. This is like the classic approach has been proposed for pollution. There's some questions about whether it's ethical, whether this could be sort of coercive, particularly in low-income settings. It's a question of whether it's fair. What about HIV-negative people? Should they not be paid? It's complicated. And then there's questions about whether it's effective. Is it sustainable? Does this extrinsic motivation replace intrinsic motivation? There've been a few examples where this has actually worked, and so one just sort of across the river, showing that financial incentives for viral suppression actually worked in the HPTN 065 trial. In a trial in Tanzania, Sandy McCoy looked at whether food baskets or transfers to encourage people to initiate helped, and found that they did. And I think there's sort of an increasing sense that when you use cash, there's a behavioral aspect to this too, that you're not just trying to get the price right, as I sort of said somewhat cheekily before, but you're actually trying to help people over some hurdle, some behavioral hurdle, where you can get them to start, maybe they'll learn that they like treatment and stay on. So this is sort of, now this is moving also into the nudge category, which I'll talk about in a few minutes, but we could pay people. We could lie to people. I would argue this is effectively what we're doing. We tell people that there are large benefits to themselves. This is what we do with vaccines. This is how the WHO guideline was messaged in 2015. I'm not like, when I give this in public health settings, I sometimes, when I mention this, I sometimes get lie to them. It's interesting. I don't know. I mean, this is sort of fear campaigns. This is what we do. We lie to people about the actual risks of different things in order to try to get behavior change. And there's evidence that it can be effective. It probably is in the short run. There's a question about whether it's effective in the long run or whether it compromises credibility of the scientific and public health community. Whether one more scare tactic is just fake news. And there's a question about sort of patient autonomy, like individual autonomy. Should people have the accurate information to make the best decisions for themselves? 4, we can nudge people to do it. We can move them along the cascade by changing the cascade, changing the default options, removing small obstacles that have outsized impacts on patient decision making. For example, it's really annoying taking multiple pills. Like, it's really annoying, and patients said that it was really annoying. And so there was a shift from 3 pills to 1 pill. And it's kind of amazing that this matters, but there's a quality of life aspect to this. And and when South Africa did this, the local doctor said, we hope and expect that adherence will be better as a result of having only 1 pill to take. So we did a regression discontinuity analysis to see whether that was true. And this was the shift in percent of patients starting ART who were prescribed fixed dose single pill therapy versus 3 pills. And we actually found that they were less likely to have a lapse in care, and they were less likely to not be monitored for viral suppression. So I guess those are both strangely defined, but things got better in the post-treat with fixed dose combination, and this was a meaningful intervention. So, like, what other small meaningful interventions are there out there, and are there things that would be helpful in sort of moving people over these hurdles? I would argue that immediate ART eligibility is another one of these. I mean, for people who were not immediately eligible for ART, they were asked to come back 6 months later and have another CD4 count. And if everybody did, then the health impact would have been probably much smaller. But what we find in another regression discontinuity study in rural KZN is that there's this discontinuity in people starting. There's also this discontinuity in people being retained in care. So people who don't start are also lost and are not coming back into care. And so there's this sort of missed opportunity by letting someone walk out the door. With immediate eligibility, you're removing this little barrier and saying that we're going to remove this decision point. Fewer decisions, the better. Just kind of move people along. Same thing with same-day ART. So there's been some discussion about the ethics of nudges. And the argument is basically this: people have poorly formed preferences. Therefore, and their choices don't reflect, or there's actually 2 arguments. Either people don't have poorly formed preferences, or their choices do not reflect their preferences, and therefore their choices don't reflect what's best for them. And so behaviors are guided more by default options and framing effects rather than what they actually would like to do. And as a result, we are in a situation of paternalism where, regardless of what we set as a default option, it's going to matter. And so therefore we're in a position where changing the default option, changing aspects of how people make decisions, is an opportunity to intervene. And going back to the McCoy study, preferences may actually change if people try it. And so there's sort of this feedback loop from this argument about changing the cascade, perhaps back to demand for art. But questions remain. How much information should patients have about their choices? Should they be informed about the social rationale? How much should we guide people towards the social optimum when we nudge versus their individually preferred optimum when those differ? What's our obligation? Is it to society or to the patient? And for effectiveness, what happens if we nudge too hard? In rural South Africa, an HIV counselor that I have been collaborating with said, these days patients don't want to get tested because they think that they're going to have to start treatment. Now, they don't have to start treatment, but they're going to be pressured by the nurse into sort of, this is what you do now. And so if we nudge too hard, then there could be downstream consequences. Finally, we could also just motivate people based on the social benefits. We could tell the truth. We could sell TASP on its merits. Prevention is a primary rationale for treat all. This shows you the effect of art in reducing new infections versus reducing clinical events. The primary public health rationale has to do with reductions in incidence. But this is like the big hush hush, because this is not in existing counseling guidelines. Don't mention treatment as prevention. It's not incorporated. This is in South Africa. It's not incorporated into HIV counseling. There have not been large-scale public information campaigns about this. There are gaps in knowledge about this amongst counselors. And this is in spite of the fact that HIV treatment as prevention is the best secondary prevention strategy, better than condoms and better than PrEP. Now, there has, in the last couple of years, been an enormous surge of interest in the U equals U campaign, which has done amazing things and gotten high-level support behind consensus statements that U actually equals U. U equals U has now been embraced by organizations in almost 100 countries, which is incredible, but it is not part of national policy in South Africa. It's not part of national policy in many other countries. So what do people believe about treatment as prevention? So as part of our K, we collected some primary data on this. We asked people using these beams to say the chances that an event would occur in glucoquinzeca and the chances that something would not occur in gecaquinzeca. And so we asked them about various transmission risks. And we asked them about the risk that a serodiscordant couple, that the HIV negative partner in a serodiscordant couple will become HIV infected if they had unprotected sex for a year. And then we asked them about the chances that they would become infected if they used condoms and if the HIV infected person was on virally suppressive ART. Okay? So this shows you the objective risk of transmission in a year in that couple, which for the science is like 1% or lower. The perceived risk is 75%. So people thought that, on average, people thought that there's a 75% risk of seroconversion in this couple, even though the partner was on virally suppressive ART. People had pretty accurate beliefs about the relative prevention efficacy of condoms. So comparing risk of transmission for unprotected sex versus risk of transmission for condoms, they said that condoms reduced risk by 70%. In fact, it's about 77%. That's pretty good. In fact, ART reduces transmission risk by 95% or higher. But they perceived that ART reduced transmission risk by only 24%. So people, these are 18, 25-year-old young people in rural South Africa, really are not perceiving ART. They're not aware of U equals U, and they're not aware of treatment as prevention in terms of the science that's been around since 2011. We replicated this study at a university in Johannesburg and found virtually identical results. So this is not just one underserved population in a rural area. This is more largely a lack of communication about this. three great reasons to do this. First is that people living with HIV, many desire to avoid transmission to partners. This has been documented in a plethora of studies. People, when they find out that they're HIV positive, rather than going out and having more unprotected sex because now they can't get HIV infected for the first time, they have less unprotected sex because they don't want to transmit. And this altruistic instinct has been demonstrated in the US, it's been demonstrated in Uganda. There's not a ton of work on this in other sub-Saharan African countries, but this is a real reason, motivator for behavior change. And so people may be motivated based on altruism to start and stay on therapy. Secondly, and linked to this, is that the U=U campaign has talked a lot about the reductions in internalized stigma, psychological benefits that people living with HIV experience with this information. That it reduces anxiety around possible transmission, it reduces feelings of potential feelings of guilt, and so on. So this has been what's reported. Those are both at the individual level, but I would argue that just as powerful is the effect that information on task could have at the community level on community stigma. Currently, here's the kind of abstracting from some of the data that we presented. What we found in our review was that many people living with HIV do not start and stay on ART because ART renders HIV visible, and they fear rejection based on HIV status. Having HIV makes it harder to find a romantic partner. So why would I go to the clinic and wear a scarlet letter? In our study, we found that 41% of respondents agreed that if I were HIV infected, it would be difficult to find a romantic partner. And 70%, and perhaps more revealing, 78% said that they would not feel comfortable having a sexual relationship with someone who's HIV positive and on ARVs. Okay, so this is like the prevalent stigma that's in the community. And if that was the community that you lived in, you would think twice about showing up, especially as a young person, showing up, starting and getting onto therapy, and having people see that you are living with HIV. Now, that's based on this perception, which is a misperception that ART is a signal of HIV and therefore a signal of transmission risk. In fact, it's the opposite. In rural South Africa, an HIV uninfected person on the sex market could reduce, sorry, that's econ speak, on the, not transactionally, in the relationship market, could reduce their infection risk by 80% by choosing a partner who's HIV infected on ARVs rather than a partner of unknown status chosen at random from the general population. Okay? So actually, that scarlet letter should be go out with me, right? It should be a badge of honor and of a marker of this is someone you want to be your partner if you care about HIV, lowering your HIV infection risk. Lord Dirksen and colleagues actually looked at this in a study in Tanzania, which is a fascinating study in which they presented information on task at the community level. They found that presenting this information reduced community level stigma. First, it increased people's knowledge, reduced community level stigma, and actually increased uptake of HIV testing. Now, the increase was from 2.6% to 3.5%, but this is at least proof of concept that this may be an important pathway, and that U=U and expanding the reach of this messaging and actually selling TASP on its merits could have downstream consequences by addressing community stigma that keeps people from presenting for care and starting and staying on treatment. So, lastly, telling people the truth is probably also the ethical thing to do. When we nudge people, it's probably more defensible to nudge people to do things if we inform that there's a social rationale, to do so. And people also deserve to know and have the information about U=U so that they can protect their partners. So can TASP succeed in South Africa? Summarizing, I say qualified, yes. It's clear from the national labs data that we're not there yet. And this is probably, I think in order to move forward, one needs to take, be clear-eyed about what the data indicate and look more at these longitudinal cascades than at just sort of the 90-90-90 targets. But I say, yes, if we can further streamline the cascade to remove these additional obstacles, which are happening, to enable people to test, start, and stay on treatment, if we help reduce the costs, particularly around these hurdle points of getting people onto therapy, if we communicate the social benefits of early treatment with U equals U and appeal to people's intrinsic altruistic motivations and the psychosocial benefit that they will realize from sharing this information, and if we respect patient autonomy and decision making, we can actually close this loop. Yes, there's this ethical tension, but we can address this ethical tension and have more effective programs if we take seriously, how people make their decisions, the real costs that they do face, in supporting them and making the best decisions that they can. And I think if we can do that, then we're likely to reap a large share of the public health social benefit that we're currently not reaping today, without resorting to some of the unethical options that I described, which I think we should never do. And I will leave it there.
Thanks, Jacob. Any questions? We have a microphone sitting around. So, hello? Okay. Thanks. That was great. And I liked getting into the patient side of things a little more. I've always struggled with how little we speak to patients about, well, first of all, like what they're experiencing, and but you allude to, what do they prefer? I mean, there are lots of ways to deliver universal test and treat, and we as the implementers and public health people, I think, have a pretty clear idea of how we think it needs to be done, and that's what we move forward with, but it may not at all be well matched with the optimal way, which we don't know. We have to figure out what it is, that it could be rolled out to get at some of the benefits you're talking about. So increasingly, I'm seeing, and probably you have too, in the African setting, the use of discrete choice experiments, another sort of economic theory-driven approach to understanding the utility of different or preferences that people have for different things. And I'm wondering if you, what do you think about this strategy as a way of getting at some of these issues? It doesn't get past the problem you raised about when people may not really know what their preferences are. But anyway, what are your thoughts about discrete choice experiments?
There have been a number of recently and increased interest. I think it's an interesting approach, and I think one would need to specify very carefully what the different options are. I mean, I think what I outlined was at a very fundamental level. There may be some people for whom it's optimal to wait, for whatever reason, and I've not seen a discrete choice experiment on that. It's odd. What I've seen mostly are small tweaks about, would you like to be biologically monitored every 6 months or every 9 months, or this, or receive your pills here, receive your pills there, which is important work. One of the challenges of discrete choice experiments is that it requires that the experimenter has the full universe of options and the full universe of dimensions at her disposal at the beginning, so that participants are choosing from scenarios that have sort of pre-specified characteristics. And I think, if that's preceded by a lot of qualitative research, that can be really effective. But I think that the first part of that sentence is really important. And, you know, I think we shouldn't get so wrapped up in the numbers that we should forget to ask people, you know, why did you make this choice? I think it's, you know, what came out of that qualitative lit review is, in a lot of cases, people can give really sensible reasons for why they made a choice. And sometimes it's based on misinformation, like they heard stuff about side effects from the old regimens that is no longer true. Okay, now you develop an intervention to address that information, right? And sometimes it's, you know, sometimes no one mentioned treatment and prevention because nobody knew about it in that study. So, you know, something that sort of interesting to try to figure out how to talk about in the context of that review. But I think, you know, I think in understanding people's decision-making, we need to do a lot, especially as quantitative researchers, we need to do a lot of engaging with just asking people. Great difference between social sciences and physics. You can ask atoms.
Hi, thanks. Is it on? Yeah? Okay, thanks very much. I am a qualitative researcher, so I appreciate what you've said about it and how important it is to bring that work and those analytic approaches into the frameworks and the way we're thinking about these questions. In terms of your work, I'm wondering, have you thought or explored the sort of organizational or provider level dynamics that might be mediating some of these outcomes? You mentioned some of the rapid initiation reactions on the part of patients. I'm doing a small pilot piece of work looking at the rollout or the initiation of policies, rapid initiation policies in New York City, and finding that providers are imposing norms about readiness and views about how to engage patients and the timeline to engage them and the kinds of laboratory confirmation data needed to make testing or ART decisions, even in light of, you know, sort of more widespread policies. And that might not be the case in South Africa, but just wondering how that level feeds in.
Do you mean that providers here are continuing to essentially use the same heuristics or criteria for readiness they were using before, rather than reconsidering the?
Yes, complicated.
Okay.
There's more variation of pathways rather than substitute new logic.
Yeah. So I think one of the, you know, this is one of the distinctions between New York City and in the public sector in South Africa and in a lot of other low and middle income settings. That providers in this setting are nurses, typically, whose job is to follow rules, primarily. And diagnoses and treatment decisions are really rule-based. And I'm not saying that that's all that they do, but its care is much more algorithmic, which has the benefit that when you change a policy, boom, it happens. And I think you're telling a story of where when you have more independence of providers who think that they know better than the system, then you have slower dissemination. It also, the less flexibility has negative consequences. Obviously, also because every case has to shoehorn itself into the guidelines. But you know, so I think what I've heard, and this is now sort of anecdotal from colleagues who are working in clinics there since UTT, is that some of them are sort of implementing the new guidelines, but chafing because they feel like clients aren't getting the adherence counseling or support that they were otherwise. And it's much hard, you know, there were systems set up such that you would do all these steps and then you would start and then you were kind of like, great. And now people are starting and systems aren't perfectly set up to keep doing those adherence, you know, visits and adherence clubs and social support components once someone's on treatment, that doesn't always happen as seamlessly. And so there's some feeling like they're being told by the guidelines to provide worse care, is what I'm hearing. So more opportunity for qualitative research.
Thanks for the talk. I'm a physician here and also do work in Rwanda on a K looking at the implementation of Treat All. So I guess one thing I really appreciated about your talk, first of all, is that it really kind of spoke to two truths. One is that humans and human behavior and, within HIV and everything else is very complex. And the second, I think, is that it's probably actually going to require sort of thinking about all of these different strategies, right, and thinking about all of these levels at the same time. So, I think we have our treatment guidelines here for whatever disease, and as a doctor talking to patients, I think you try to fit, 17 different types of pegs into the one hole here, right, because that's how it is. And in Rwanda, I think some of these things have come out as well. So we did a quantitative analysis, and we saw that the number of people starting medication within 30 days of enrollment jumped up a lot after they implemented Treat All. And now we've been doing some qualitative work, and it's also been interesting because patients say, well, we like Treat All, we think it's a good thing for the country, but we feel super stigmatized when we come to the health center, and we feel stigmatized at home, and it's hard for us to take our medication. And so I think, again, speaking to the real complexities and the need for a multi-pronged approach. So that's sort of my commentary. My question is, I think things will require individual level interventions and systems interventions and community sort of societal interventions. And so you talked about that at the end with U equals U and sort of changing the landscape. And I wonder if you could talk a little bit more about whether similar efforts in other types of places or other disease processes have actually successfully moved the dial, I think, in terms of increasing, for HIV, right, and the number of people starting medications and staying on medication.
So I can speak. First, thanks for the description of what's happened in Rwanda. That's really helpful. I can speak to some of the evidence on. Let me speak narrowly to sort of, is there precedent for giving people information about social benefits and motivating behavior? Is that responsive to your question? Okay. So there's evidence from vaccines that if you tell people about herd immunity and the social benefits of vaccination, they're more likely to get vaccinated over and above just giving them information about the individual benefits. America. There's evidence. Well, it's not a big effect, but there's evidence. I think there's proof of concept here from HPT 1052 in the qualitative, in interviews with participants, they found that altruism was a huge motivator for people to adhere to therapy. In PMTCT, as soon as, if you tell a pregnant woman that she can prevent transmission to her child, she takes her drugs. And she stops as soon as you tell her, yeah, it probably doesn't matter as much anymore. In fact, that's been a major problem because there's still fairly high transmission during breastfeeding, which probably would be lower if people stayed on meds, and retention after birth. That's a whole other thing. But there's so I think there's at least there's preliminary data. There's evidence that people make decisions with altruistic motivation. So at least as a part of counseling. And I think there's also evidence that there's psychological benefits to U equals U. So I think that, this should be integrated into counseling is part one. In terms of what happens when you disseminate broadly information campaign like this, we have to think more about a comparison. We were talking about the opioid epidemic earlier, and it occurred to me whether there's a similar question around, care seeking for medication for people with addiction. In terms of there's so much, what role stigma plays in that, and what role a changing conversation around addiction could have. And I think you see that with HIV treatment, the initial rollout of HIV treatment, that it's more normalized and people are more likely to take up, and in the ledger, stigma's not so high that it's not worth taking life-saving medication, where that was true in some places at some point in time.
Dr. Bohr, Okay. Dr. Bohr, that was a fantastic presentation, and I just wanted to add, have you ever heard of people applying these same methods that you have been describing to non-communicable diseases such as diabetes? Because I do an awful lot of work with the Rogozin Institute, which is focused on kidney health, and we're trying to accomplish a similar type of social drive, so to speak. And what you had described is, in this research, I saw so many similarities in terms of the initial buildup to getting diabetes, getting diagnosed, and then having to go on dialysis while you're waiting for a kidney transplant. And what we're trying to do is trying to reduce that instance of dialysis and no return when you're on end-stage kidney disease as a status. Has anyone ever explored any parallels with this relative to your work?
There's definitely a growing literature on sort of the non-communicable disease cascades of care. I think that there are two big behavioral challenges with HIV treatment and prevention, and one is how do you get people to adopt a new lifelong daily habit where the benefits to yourself are over a long period of time in the future. And so this is the non-communicable disease screen, this is the chronic, this is the aspect of it as being a chronic, therapeutically managed chronic disease, which is similar to diabetes. The bit about, the treatment and prevention side, I think is clearly different, but there are other diseases, other chronic communicable diseases that for which there are similarities. And in fact, treatment as prevention is the dominant approach for TB these days. We used to do case finding and quarantine, but it's the dominant approach for TB. It's one of the dominant approaches for malaria, even though it's a much shorter course. So the idea, therapeutic management of infectious diseases has a big prevention benefit, and so that's sort of, I think that stuff is separate, but the part about a long-term management and care and how to do that well, I think there are lots of parallels.
Okay, I have one question. You made the analogy to vaccination, social media campaigns, and people who are actively promoting not getting vaccinated for various reasons. And I was wondering if you had any thoughts about the impact of that kind of thing with HIV treatment.
I do. I think that it raises a broader and deeper question about the future of public health information campaigns in the era of so-called fake news and sort of falling ability and interest, and those are endogenous to each other, of the public to distinguish science from not science. I think we probably, as a public health community, I'm going to take a generous perspective here. I think as a public health community, we do a disservice to ourselves and to the general broader public when we lie to them. And I think that increasingly people are smart enough and have access to the underlying science to be able to call us our BS. And so I think we need to be much more careful. Like the rise of fake news, quote unquote, and the rise of stuff like this, I think actually requires us to double down on the rigorous empirical foundations of what we're doing and thinking about how to communicate that, rather than playing this game of can we have the most flagrantly tweetable clickbait that we should use as a campaign. I'm not saying we, I don't know. I can see I can see both ways, but I think we can do the clickbait so long as the form can match, but the function needs to be linked to rigorous science. I think that's how I would respond to that. Yeah, there's a lot of that, and I think in combating that, we just need to make sure that we're staying as close as possible to the empirical evidence, and that's where how we talk about U equals U, how we talk about tasks, how we talk about you can't start treatment until you stop drinking. Like, what's that? But we need to like get our house in order, because there's this threat that people will dismiss what the public health community has to say, just as they dismiss the latest tweet.
Thanks very much, Jacob, for a great and thoughtful presentation, and thanks everyone for coming out to hear it. Have a good night.